through chapters. There are 7 chapters total that we're gonna go through. And each chapter has a title, and each title is a line from a movie. And that line basically is the intro to what I'll be talking about in that given chapter. So I challenge you each, and I involve my audiences, not to put any pressure on you or anything like that, but when I shoot the title up there, you tell me where it came from, and then I have other things I'm gonna always be asking you guys questions about. So, chapter 1, I have a feeling we're not in Kansas anymore. Where's that from? Thank you, good, you guys are good, all right, that's good. So, here's Jasmine. Jasmine presented to me in October of 2021, originally from Hannibal, Missouri. She's 25 years of age at the time she presented to me. She has a history of terrible childhood, domestic, medical, and dental abuse. Horrible enough to say. She has full body CRPS, including internal organ involvement. And she was first diagnosed at age 13, but when I show you some of the things she's been through, you're gonna see that she was probably symptomatic much earlier than that. Okay, now here's some of the full body CRPS symptoms she presented with, and I'm sure dispersed throughout all of you, I'm sure you have some of these things, and if not all. She had all of these things. It was full body numbness, spasming, back pain, gastroparesis, stomach pain triggered by eating or drinking, chronic constipation, chest wall pain. You get those spasms to the intercostal brachial nerves, bladder spasms, and severe leg pain. Terrible. Okay, now she was referred to me by the RSD Foundation for dental care. She was having some dental problems, and I'm a dentist. And when she came to me, she flew in literally the first day, brought her in. I set up in advance for my patients. We get things we're gonna be doing, but here's her symptoms to the head, neck, and face beyond the other symptoms she already had. She had severe facial pain. She had severe pain in the jaws with and without movement. And she had severe pain into her teeth. And she had severe head pain, the back of the head, the top of the head, the front of the head. And she had severe neck pain. And you look at this, you can say, well, you got CRPS, you're a chronic pain patient. Or you can say, wait a minute, all pain can be traced to its source. Let's just see how we can start to cut this thing up a little bit and start fixing things, if it's there to be fixed. So, here's how simple you can start to make this thing, to start to figure out what's wrong with somebody. Rather than look at everything in total, I do this. Here's a very simple diagram of the head, neck, and face. And you look at this, there's really 2 parts to this. There's the neck that can cause a lot of different kinds of pain. There's sensory pain from the neck, and there's sympathetic pain from the neck. And that pain can refer. Then there's also the trigeminal-based pain, the 5th cranial nerve, the so-called TMJ pain. And if you look at these 2 areas, you see this encompasses the whole head, neck, and face. So every patient that comes to me as a starting point, as part of my initial workup, gets an MRI of their TMJs and an MRI of their cervical spine. Now the question is, why do I do that? What's that got to do with CRPS? Because I'm here to tell you about CRPS and all these things. Why is it necessary to image the joints and the cervical spine? To begin to answer that question, this is right out of Dr. Hushman's classic book on chronic pain. Dr. Hushman, a true giant in the arena of CRPS and sympathetic dysfunction. He was a neurologist and also a very accomplished publisher and researcher and such. He just passed away a couple of years ago. These are quotes right out of his book. Quote number 1, cervical spine pathology causes sympathetic dysfunction. If you injure your neck, you can get CRPS. Okay, it doesn't matter where your symptoms are showing itself. If you injure your neck, that could be the trigger for whatever type of CRPS your body shows itself as. Number 2, cervical spine pathology frequently accompanies CRPS. Okay, that means if you've got CRPS, you're probably gonna have something wrong with your neck. Something is going on. And again, it behooves you to get your neck looked at. If you've never done that, you look at cervical spine, and sometimes you're gonna see things that are wrong, that if you fix them, it might be a way of tamping down your symptoms. Number 3, very important from a dental point of view, trauma to the cervical spine can refer pain, mimicking the so-called TMJ patient, but it's coming from the neck. That's what leads to a lot of false diagnoses, atypical, idiosyncratic and such, because they miss the fact that it's a pain referral mechanism. And it actually looks like a TMJ issue, 5th cranial nerve issue, but it's coming from the neck. So you can have a jaw joint issue that refers to the neck, and you can have neck that refers to the face, or you can have both, any combination. So this is why all patients who come to me with a severe head, neck, and facial pain and CRPS to the head and upper torso pretty much, MRI, cervical spine, MRI, TMJs. I'm looking for injury and I'm looking for some sort of pathology. Okay, and this is a final quote from Dr. Hushman's book, and I feel it's still true today. Unfortunately, the role of cervical spine pathology in RSD has been recognized by few clinicians. That's from 1993. I think it's still true today, because when patients come in to me, I ask them, did anybody ever look at your neck with all the things you have going on? And they say no, okay? I'll say it over and over, all pain can be traced to its source. You just gotta keep looking. Okay, so just to show you basic and how simple a frontline diagnosis can be, this is an MRI of a normal TMJ. This is one of my patients that didn't have a TMJ issue. I don't have to tell you what you're looking at. Just look inside that yellow circle and look what you see. That's a normal TMJ. Okay? This is Jasmine's TMJs, left and right side. Look inside the yellow circle of Jasmine's TMJs, left and right side. Does what's inside those yellow circles look like the normal one? Anybody, yes or no? No. No, not even close. In fact, this is a horrible, what's called an osteochondrosis. This is a pubertal damage to her jaw joints. And there's a way, when you look at this, when you know how, you can measure age and stage this kind of damage. She's had this since before the age of 10, and this is trauma-based. This is not genetic, you're not born with it, it's not acquired, this is from trauma, period. And this is extremely and exquisitely painful. So prior to the age of 10, she's walking around with these horribly internally damaged jaw joints that nobody ever thought to investigate. When she moves her jaws, she gets terrible pain that goes into her face, shoots into her neck, and would put her into these spasms that I witnessed when she first came to me. Okay, so this is surgical. There is a time for surgery, and it has to be fixed, because if you don't fix it, that pain will never get accounted for and never go away. So take a look at Jasmine. This is back in the fall of 2021. You guys know this. Look at that face. That's the face of somebody in horrible pain. You can just see it. Okay? We set her up, and she had the TMJ corrective surgery. Here she is post-surgical recovery, and she has this surgical stent that's rubber banded in that she wears for a couple of months just to immobilize the jaws while the TMJ surgery heals. Now, here's the thing. I know you guys are told that you should not have surgery when you have CRPS, correct? Okay, that's true unless you know how to control the sympathetics as part of the surgery. So what gets done here? Surgeries and dental procedures can be done on patients who have CRPS if you account for the sympathetics that supply that area. So I'll show you in diagrams is there are very specific types of sympathetic nerve blocks that can be done, that if you administer them before a procedure, during and after, you can keep the sympathetics out of the equation. So number one, they won't react, and the body stays unaware of what you're doing, and then the body can respond appropriately and be treated appropriately. So you can have any dental procedure done. Because I get people that come in, I was told I can't do this, I can't do that, I shouldn't have root canals, I shouldn't take up my tooth. Yeah, that's all nonsense. If you block the sympathetics to the part of the mouth you're talking about, you can then go ahead and do the dental procedure that you want to do. And oftentimes, when you block the sympathetics to a given part of the mouth, that abates their symptoms. So the dental procedure that you thought it was going to be isn't even real. Because when sympathetics hits the mouth and hits the teeth, you're going to get these teeth that are hot and think it's, uh-oh, it's a root canal. And that's where root canals maybe gets a bad rap with regard to CRPS, because the problem was not the tooth. The problem was the CRPS making the teeth get hot, making your gums hurt, making your gums swell, and making the muscles be in spasm and such. Okay? Now here's the second thing that's very important about this type of reparative surgery done on CRPS patients. The repair that's done is called a fat graft. And fat is harvested from the bikini line, below your belly button. The soft tissue that she had was damaged at a very young age and could not be fixed or repaired to keep in her mouth, so it all gets removed, and what goes in instead is fat. That becomes the new cushion between the lower jaw and the upper jaw. And what's unique about doing these fat grafts on CRPS patients is this. Sympathetic nerves are non-myelinated nerves, and as such, they don't have any fat sheath on them, and therefore they will not transmit through a fat graft that's placed into the jaw joint. So right off the bat, we take these symptoms and we knock out these terrible facial pain, jaw movement pain that she had within the first few months of her coming to see me. Because it was the issue, the trigger, was a horribly debilitated jaw joint, and we had to take care of that, fix it. That fat graft goes in, that fat graft stops the transmission of non-myelinated sympathetic nerves from transmitting through it, and stops that pulse going into the back and triggering these other CRPS symptoms that she had. So, I say to you, there's no such thing as chronic pain, idiopathic, idiosyncratic, or atypical pain. there's pain that wasn't diagnosed. I could not believe that at the age of 25, at least 15 years or so, that she's walking around with that kind of debilitated state that nobody ever thought to at least examine and pick up on. And you don't have to know the nuances, but if you just did a basic imaging type study, you would see that's not normal. Find somebody to do something about it. Okay, all pain can be traced to its source. Okay, now, the other thing, the reason Jasmine was referred to me, and this takes us into a more general dental round, was for routine dental care. She was going to a dentist back in Hannibal, Missouri. She has CRPS, they know it, and they basically said, you have these cavities, but we can't get you numb to work on you. And because we can't get you numb to work on you, they panicked and they said, can't get her numb. And instead of sending her to a sedation dentist, which are all over the country, there's a sedation academy. They deal with patients who hate the drill, hate the dentist, can't stand the noise, whatever, and they put you to sleep. They put you to sleep and they can do your cavities. That's general dental work under sedation. This dentist sent her to an oral surgeon who, on their recommendation, put her to sleep and extracted 5 permanent teeth that never should have been. All her back teeth were extracted because they couldn't get her numb. I was dumbfounded when I heard that. I could not believe that she was telling that story. That was my reaction. I said, I've never heard of saying any dentist say, I can't get your numb extracted tooth. You're gonna have this, I'm gonna do something for your eye. Oh, I can't get your eye numb. Well, we're gonna cut it out. We'll cut off your finger, we'll cut off can't get your numb, cut it out. That is negligence, in my opinion. Okay, so here's the deal. This is the nerve blocks I'm talking about. What we can do, what I do every day, is we have what's called the superficial cervical plexus. And that's this plexus that's sitting right here, and the hub of it is called Erb's point. And basically you have these sympathetic nerves that come out of your upper cervical spine, C2, C3. They're deep, and then they come superficial, literally right behind the sternocleidomastoid muscle, just tucked in about midpoint, and that hub is sitting. This is not a deep injection. It's just under the skin. It's called the superficial cervical plexus block. You can block that hub, and you knock out all the branches on that side, or you can do individual. So there's a branch that goes to the front of the mouth, to the mid and back of the head over to TMJ, or you can just do the TMJ itself. This is how you take on a dental patient with CRPS. Straightforward, simple. These are easy injections to learn. Block the sympathetics, then you go in and do your normal Novocaine in the mouth, and now you can perform your procedure. The other thing that's so important, especially with any surgery, extractions and such, is when you block the sympathetics, you're also stopping the sympathetics from causing vasoconstriction. Remember, CRPS is a vasoconstriction of blood vessels. You don't want that to happen when you want healing. You want blood supply to an area. So when you block the sympathetics, besides taking it off the table, so it doesn't influence what you're doing, you're also keeping blood supply going. And something else, while I'm on it, patients often say, since I got CRPS, my teeth got weak. They keep breaking and such. Your teeth don't get weak when you have CRPS. You're not pulling calcium out, you're not demineralizing them and such. What's happening is you get what's called a cyto event. Cyto stands for sympathetic induced dystonic occlusion. That's a fancy term for the sympathetic nervous system. The dysfunctional sympathetic nervous system unplugs the normal trigeminal nerve innervation to the jaws, the teeth, the gums and such, and it plugs itself in. So now you've got this dysfunctional sympathetic nervous system that's telling your muscles what to do, how to hold your jaw, how these muscles should contract, and you get way too much force generated in an atypical manner, and you're going to start breaking teeth. You're going to be sitting like this, you're going to sit like this, and people coming in with facial fasciculations. These muscles are in such terrible spasms. And the answer is not mouth guards and other things you might have had exposure to. The answer is block the sympathetics, because they take effect, these blocks, in about 10 minutes, and all of a sudden everything relaxes, bites can normalize, and you can treat. Okay, so here's Jasmine as she presented to me. It's terrible. Look behind the backmost teeth. See that space? That's where she had teeth that had cavities similar to what you see here on the bottom. Those little brown holes, those are cavities. Okay, she had all the other teeth extracted because they couldn't get her numb. That's just, I don't know what word to even use to describe it. Horrible. Okay, because when you lose those teeth, you also lose the bone. The bone you lose the teeth, bone doesn't get stimulated, bone shrinks up. And that becomes a major problem. She's 21 years old when they did this to her. Okay, so now she's afraid that they can't get me numb. I blocked the sympathetics. In this case, I did the green one, the greater auricular nerve block. That stops all the sympathetic innervation to that area of the mouth. Then I numbed her in the mouth just like routine dental care. and you can fix these teeth. That's just basic cosmetic restorative dentistry. And I'll tell you, she felt nothing, okay? Nothing hurt, because I took the sympathetics off the table. That's how you do this. So you can have any dental procedure you want to have done, that you need done, can get done. Cleaning, I can do with I'll just do 2 herbs once. It blocks everything. With 2 injections, now your mouth can be cleaned, fillings can be done, root canals can be done, extractions can be done, whatever it needs to be done can be done. You just got to account for the sympathetic dysfunction first, okay? That takes us now to Jasmine's journey to chapter 2. This chapter, I'm gonna need your help, because the title for this chapter is called Responsive Reading. I'm gonna read the lines in white. You're gonna read the lines in lavender. Everybody with me? Okay, I got the first line. You want answers? You guys, come on. Thank you. You want answers?
I want truth.
Right, now together we're gonna say this, 1, 2, 3. You can't handle the truth. Thank you, now be quiet. Okay, so Jasmine comes in. I'm just gonna get you involved. Watch what's gonna happen to Jasmine. I said this kid, Jasmine. She's still, we fixed a lot of things. We fixed that jaw pain and such, but she still has all these horrible symptoms, mainly this headache pain and severe neck pain and such. Okay, now here's what's neat about these blocks. If you look at the sympathetic nervous system innervation to the body, it's not nerve to area like sensory. These sympathetic chains all communicate with each other, head to toe and left to right. So when I give these blocks, very often she'll get relief to other parts of these symptoms that she has. The problem is this: she breaks through. A lot of times, if somebody's not that sick, you do these blocks a couple of days in a row. These blocks can be repeated as often as necessary. And then you see, sometimes if somebody's not that sick, they get relief and it holds them for quite a while. But in her case, she keeps breaking through, so something else is going on with what she has. And I say again, I live by this. All pain can be traced to its source. So we have to say, what else could be going on here? So she has this pain to her face and the mouth that radiates, and the back of the head, we know, and the neck pain and such. And I said to you that you must get an MRI of the cervical spine, because that could be what's causing her problem. So here's the MRI on Jasmine's neck. And again, I'm not here to tell you everything that's up there. That's a side view and a front view of her cervical spine, and the yellow outline is the area that I concern myself with, because the upper cervical spine is what gives rise to those nerve plexes that will refer to the head, neck, face, mouth, and such. Okay? So some of the things I look for on the MRI is this. I look for disc herniations. Is the disc that's between the bones, is it in place, and does it look okay? And I look to see if the vertebrae in alignment, is anything out of place where it might be touching the cord and causing a problem. And then we look to see if there's any stenosis, that's narrowing. Is there any place where those nerves exit the spinal cord, where maybe the nerve's being pinched? Those are the things you can look for. And then most importantly, on every CRPS patient, we want to look for this: Chiari malformations. Hands up, who's had a Chiari or has a Chiari? 1, 2, 3. Any over here, I see? Okay, so I'm going to do this throughout. As I show you problems, I want to see, just as a poll to the audience, how much overlap we have. So Chiari malformation, let me show you what this is. This absolutely plays back to CRPS. What is a Chiari malformation? Okay, this is a Chiari malformation. This is a side view of Jasmine's MRI up close. Chiari malformation is when the base of the brain, now draw a line, is when the base of the brain starts to sag through the opening where the spinal cord begins. The spinal cord is basically a continuation of the brain. The reason this happens is because you could say the skull is a little too small for the brain, or if you want to feel good, you say your brain is too big for your head. Whichever makes you feel good. Either way, the brain will sag down out of the place it's supposed to be. And that little sag below the yellow line, that's the Chiari. Now, here's a caveat about Chiaris, because I have patients come in who have Chiaris diagnosed, but they're told it's too small, it doesn't matter. That's absolutely false. Chiari malformations, it has nothing to do with the size of the Chiari. The question is, do you have symptoms of a Chiari? And if you do, it has to be investigated. Okay? The size is irrelevant. You could have a small Chiari that's significant. You could have a big Chiari that's not doing anything. Okay? If you have a Chiari with symptoms, you have to get what's called an MRI of the brain with a cerebral spinal fluid flow study. CSF, that's the white stuff that you see up here. All that white is fluid bathing the spinal cord and perfusing throughout the brain. Okay? Because the problem is, if that Chiari is sagging and causing a blockage, that around that red circle is where you're going to see it. And what'll happen is on the flow study, all that white will just probably be black. It's dark because it's not getting perfused. Okay, it's a very easy MRI to have done. It's an MRI, about 20 minutes. They hook up a pulse ox to your finger, the other end plugs into your, to the MRI, and they sync up your heartbeat with the flow of the CSF fluid. Just like when your heart beats, it pumps blood throughout your body, it also pumps the CSF fluid through your spinal cord into the brain and makes a big circle and comes back. So if you know where that white channels are supposed to be and something stays dark, that's a sign of a block. Okay, now if there's a blockage, what you have to worry about is what's called a syrinx. The syrinx then is basically a bubble in the spinal cord, and if you get that, that's bad, because now the spinal cord is actually being affected. That can really get you into trouble. Okay, and if that's the case, that becomes a surgical intervention. Okay, now these are all the symptoms of a Chiari. Why is a Chiari important to CRPS patients? Okay, look at what's highlighted in blue. Here's my CRPS chart that I put up, and I blue starred the overlapping symptoms of CRPS with Chiari. Okay, so the point is, if you've got CRPS and you've got symptoms that are not responding to treatment, and you get an MRI and you see a Chiari, you might have a Chiari that's causing the problem. It might not be the CRPS. The CRPS is sympathetic. That's outside the spinal cord. The Chiari is going to be more related to your cranial nerves. You see, so you have to investigate this, because if you're not responding to treatment, you have to say the treatment is wrong or the diagnosis is wrong. Okay, so it's to your advantage to always get your neck looked at, because if you have symptoms that are not resolving, it could be you have a Chiari, it could be you have a blockage, and the way you find it is with a simple MRI. It takes 20 minutes. No pain or anything like that. Okay? All pain can be traced to its source. So with that said, Jasmine had a CSF flow study, and hers was negative. She had good perfusion. There was no blockage. That was the first thing I was concerned about when I saw that, because again, it had never been investigated. Okay, so here's the problem. She still has this horrible rear head pain, neck pain and such. Can we tell her, well, you got CRPS chronic disease, you're gonna have this kind of pain, you have to learn to deal with it. We don't do that. Okay, I don't do that. That takes us to chapter 3. Now, you don't read this one, I'm gonna read this one.